So good morning and welcome to the Department of Medicine Grand Rounds. My name is John Inadomi. I'm the Division Head of Gastroenterology. And this is our annual Wade Bollweiler Visiting Professorship. Before I introduce Dr. Hashem El-Serag, who's the Professor of Medicine and Duncan Endowed Chair and Chairman of the Department of Medicine at Baylor College of Medicine in Houston, I'll tell you a little bit about Dr. Bollweiler. Wade Bollweiler was the first Division Head of GI. I'm the fourth. Dr. Baylor was born in Grand Forks, North Dakota, attended Oberlin College, and received his MD from Harvard. His internal medicine residency and GI fellowship was at the Mass General Hospital, and research training was at the Mayo Foundation. He was recruited to UW in 1949 and was the division head for the next 31 years. So Bill, I'm a quarter of the way there. That's it. His research interests included hepatitis and cirrhosis and celiac disease, malabsorption, all of which are very relevant even in today. And became the president of 3 major national societies, including the American Association for the Study of Liver Disease, Western Associated Physicians, and the American Gastroenterological Association, where he received his Lifetime Achievement Award. With that background, I'd like to introduce Dr. Hashem El-Serag. Dr. El-Serag received a medical degree from El-Serag University in Benghazi, Libya. Started with an internship in surgery, and then saw the light and actually emigrated to the US and completed an internal medicine residency at Yale University. And then was recruited to the University of New Mexico, where I met him. He was my first GI fellow there. And of course, I was a new attending. During that time, Hashem received his master's of public health. And based on the work that he did there, essentially published a single author study of the epidemiology of hepatocellular carcinoma in the New England Journal of Medicine. So with that, just launched his career and was recruited by Nelda Ray and Linda Rabinek to the VA Medical Center of the Baylor College of Medicine in Houston. He was the chief of clinical epidemiology and outcomes research for the Houston Center of Quality Care, and then recognizing his administrative talents, was then promoted to the chief of GI and hepatology at Baylor College, where he remained in that position for a decade. Actually, you still are. Okay, I was going to say, you think you still have that title, and the director of the Texas Digestive Disease Center, which is a P30 center grant from the NIH for Baylor College. And this year, he was selected to be the new department chair of medicine for Baylor College. Hashem's research posts are quite diffuse, but they really are centered around Barrett's esophagus, which we'll talk about this morning, as well as hepatocellular carcinoma. But there are very few topics that he hasn't touched on in his 387 peer-reviewed publications that include journals such as New England Journal, the Annals of Internal Medicine, Gastroenterology, Hepatology, and all these really high-impact journals. He's the principal investigator of over 6 active NIH grants and a co-investigator on another 7 NIH grants, as well as some BA grants, including the Merit Review. I just noticing that he's had many international speaking engagements that includes Japan, Sweden, Austria, France, and Germany, and that was just this year. A variety of national honors, including an election to the American Society of Clinical Investigation, awards from all the major GI societies, a Department of Veterans Affairs Special Contribution Award for his work on hepatocellular carcinoma. Just completed his tenure as editor-in-chief of Clinical Gastroenterology and Hepatology, was a journal of the AGA, and he's the newly elected vice president of the AGA, which means he'll be the president in 2019. So this week, as part of his Bollweiler lectureship, tonight at Pacific Northwest GI Societies, he will actually talk about the 20 years of the hepatocellular carcinoma epidemic, and this is the Rainier Club around 7 p.m. for those of you who can make it. Tomorrow at our GI Frontiers, he'll talk about, it's a great talk of the tools of the trade, writing and presenting. Sounds rather dry, but I've heard Hashem talk about this, and it really is inspiring a way to understand how to get junior faculty, fellows, students, how to write and present. It really is inspiring, so I think that this will be great. But today at Department of Medicine Grand Rounds, you can talk about Barrett's esophagus and esophageal adenocarcinoma, risk factors, and prevention. And really I'd like to thank Hashem for coming here and honor his commitment. And this is in light of the fact, of course, of the devastation from the hurricanes in Houston, in addition to his new responsibilities as department chair. So really, thanks so much for coming here, Hashem.
Thank you very very much, John. Thank you for the invitation, Dr. Bremner. Before you sit down, John, each time I'm introduced by something nice like this, I'm reminded of two things. One, I should have taped it for my mother-in-law so she would believe it. The second is that I'm just astounded by this journey and how, if you consider that success, how the success was contributed to too many people who helped me along the way. And John is certainly one of them. So he has mentioned he's my first attending, the first person who I know what modeling is, and certainly people who inspired me. So, John, I'm going to get you something from Texas. So these are Texas chocolate truffles with a cowboy boot and a Lone Star and yeehaw! Yeehaw! Second, as a single fellow in New Mexico, probably one of the first homes that I've ever entered was John's home. He invited me with his wife and visited with them. And I know how much they love cooking, so I got you a barbecue chef.
I'm sure Christine will love it.
All right, so now we'll talk about esophageal adenocarcinoma and Barrett's esophagus. As he mentioned, my better talk is this evening. So this is just to go through things, but you should show up this evening. Plus the food is definitely better there. I would like to advance the slide if possible. I remember you told me it was a miracle to get me to this room. Let's continue the miraculous thing. All right, there you go. All right, so normally I introduce myself by showing the Texas Medical Center, which is the largest medical center in the world. 120,000 people work in it, all that stuff. This is how the Texas Medical Center looked a couple of weeks ago, and this is what used to be a freeway. And you see how the cars are submerged. We really got a beating there in Houston. Luckily, the facility survived, but it is estimated that 1 of 3 people in Houston have lost everything, like homes and cars, etc., including many employees. This is close to the street where we go to work, and the way to evacuate patients were boats. So we survived, and here we are, and I'll make more references about personal losses during the hurricane too. Today, I'm going to talk about esophageal adenocarcinoma. And I would like to show you what I mean by esophageal adenocarcinoma, because there's another esophageal cancer that I will not be talking about today. This is the cancer that is common in Western countries. This is the cancer where the UK, the US, Denmark, Iceland, Australia are the countries that are leading the world with the incidence of this cancer. So it gives you a flavor here, and it's the opposite of what you think of esophageal cancer, which is smokers, underdeveloped countries. No, this is esophageal adenocarcinoma, which affects this country, Western countries, and developed countries. This is the cancer that is related to reflux. So this is what many people think the spectrum or the progression of the disease, and I want to give you a flavor for how common or uncommon this thing, but more importantly, how common the preceding risk factors for it. So erosive esophagitis is 10 to 30%, supposedly, if you consider reflux symptoms. It may develop esophageal strictures. I guess there's no point of pointing here. Yeah, here it is. 1 to 2% may have erosions, and this is Barrett's esophagus, tongues of mucosa that looks like the stomach, but when you examine them histologically, they look like the small intestine, and instead of being present in the small intestine, they're present in the esophagus, and this is the dreaded eventual complication. This is the cancer that I'll be talking about, which is esophageal adenocarcinoma, and once you have, or someone has Barrett's esophagus, the risk is elevated considerably, 0.2 to 0.5% per year. This is the cancer where you hear the words low-grade dysplasia and high-grade dysplasia and what to do with them. Barrett's esophagus passes through dysplasia to get to cancer. I'm saying this based on experience. I remember giving a talk all about esophageal adenocarcinoma and then receiving questions that were completely related to the other cancer. So I thought I must have made a mistake. Let's explain in the beginning, what am I talking about here, so I don't get the same thing telling me what about Iran and Russia and all of those countries where the other cancer is common in. In the United States, it's the third fastest rising cause of cancer-related deaths. Any guesses on what is the #1 fastest rising cause of cancer-related deaths in the US? Hint, come this evening? Liver, okay? So, so I chose to work in #1 and #3. So this is the incidence and mortality, and this red squiggly line is the survival, and the 5-year survival remains really at a dismal 17 to 20%. Something very striking about esophageal adenocarcinoma in the US is it's a white man disease. So white men is that top line, black female is that very bottom line. I don't think I've seen a black female with esophageal adenocarcinoma, and white females and black males somewhere in the middle. So that's why my talk will focus on why is this happening and how can we tie it into the risk factors and how can we use the risk factors to identify people and prevent it. So I'll try to prove to you that epidemiology can be remotely useful by thinking on big picture and then drilling down, what do you do right now? This is what is really striking about the epidemiology of the spectrum from reflux to esophageal adenocarcinoma. This is not based on data, but I'm from Texas, so I don't need data. I just speak from my gut. So based on my gut feeling, Gerd symptoms, if you survey a group like this and look at Gerd symptoms as defined by having reflux or heartburn more than once a week, you'll find men, women, black, white, they reported almost the same. So they're equally divided. If you start scoping people, then you start noticing the variations or the discrepancy by it is rare to find Barrett's esophagus in a black person. It's extremely rare to find it in a black woman, while in the VA, where I work, where older white men get scoped, it's 10%. 1 of 10 scopes, you get a Barrett's esophagus. So here you start noticing the discrepancy where men, Western countries, and whites are overly represented. And if you go to the end of the spectrum, the bad part, the esophageal adenocarcinoma, that discrepancy and disparity is highly accentuated, where white men are 8 to 10 times more likely to develop this cancer than black women. So I hope that in the next 15 minutes, I will touch on the risk factors and tie them to explaining this really, really interesting and remains inexplicable variation. So I'll start by the most common risk factor that people talk about, reflux. You notice that Western countries, where studies have been done, are the countries where reflux is common. You notice that developing countries or countries that are moving to become developed, like China, Iran to a certain extent, are reporting higher rates of reflux in their population. So what does reflux has to do with what I'm talking about? It is the most common and the strongest risk factor for Barrett's and esophageal adenocarcinoma. And simply spoken, the earlier you get it, the longer you have it, and the more severe you have it, the higher risk of esophageal adenocarcinoma. So if you drill to those people who have daily symptoms, their odds ratio is about 8. Their duration of 30 or more years, their odds ratio is 6. If you put those two together and slap on them starting reflux at the age of 20, then you get to odds ratios of 10 and 20. Really, really high. So you'll hear lots of talks from me, and it's supposed to orient you as a non-gastroenterologist what to do when you have someone where you compile risk factors. I won't talk a lot about scoping today, but have no doubt about it. If you have any doubt about Barrett's or esophageal adenocarcinoma, send them to get scoped. Okay? So here again, I speak from my gut, but this whole idea is for you to have a gut like mine, where your gut is based on hopefully some data. But this is not an exercise in futility, because those are the kinds of decisions that you make among the many people who are on antacids and PPIs, and you'll have to decide where to investigate more or not. And this is the most common and strong one. The second one is a rising one. So someone smart came up with this expression, globesity, which means global obesity. The US is leading the way in obesity. Many countries are catching up. Most obese people reside in the great country of China because it's the most populous. So what does obesity have to do with esophageal adenocarcinoma? Well, obesity, as measured by BMI greater than 30, has been tied with just about everything related to reflux and its complications. So esophageal adenocarcinoma, everything to the right of the 1 means increased risk. Some show, 7, 8 odds ratios. Erosive esophagitis elevated, Gerd symptoms are elevated. But what hides behind BMI? So BMI now is linked to almost everything. And it's becoming almost not useful to say high BMI is a risk factor for a certain disease, because it's almost like breathing air now. It's so common that you can't distinguish what's bad about it. So digging beyond BMI is an area of interest both in research and clinical practice to see who are among the many people with high BMI who are at a higher risk for the entity you're interested in. So waste is what people look at. Waste is a reflection of visceral adiposity, which is the type of fat that surrounds the intestine. That type of fat is thought to be both an endocrine organ as well as a source of a low-grade systemic inflammation. So hazardous waste is important in this condition, and I'll show you how. What this picture neglects to show is the face. So this was me last year before I went on my diet and exercise, and now I look like this. Not true either, okay? So how do you link obesity to Barrett's esophagus and esophageal adenocarcinomas? Many studies have been done. I'd like to simplify them with pictures just to give you a flavor how those two entities might be linked to each other. So abdominal obesity, in it, there's visceral obesity. I'll show you a study where this green fat, quantified by a type of CAT scan, is significantly elevated among those with Barrett's esophagus compared to those without, and with those who eventually develop esophageal adenocarcinoma and those without. Then you get further and you look at the mechanism of action, and several studies showed that this fat in the belly acts two ways. One, as an inflammatory source, where it expedites the progression along the spectrum of neoplasia, and the other one is just quite simple. Many of us could attest to it. It's just a big pad of fat sitting on your stomach, so when you lie down, it expedites the regurgitation of acid content. So it has both a mechanical aspect as well as a humoral aspect, and that's why obesity is linked disproportionately to esophageal adenocarcinoma than most other cancers, where the link is mostly humoral. Here, it's humoral plus mechanical. So it increases acid exposure, but also has non-acid adipokines, cytokines, insulin, IGF pathway, etc. Leads to this endophenotype, and there we go. So this is one of the studies that we've done where we've actually systematically performed CT scans and quantified the amount of fat on patients with Barrett's and primary care controls. And the bottom line was the VAT, which is visceral adipose tissue, was greater in quantity on average than those without Barrett's esophagus. So to put it in a cartoon way, this is the link. Obesity tends to be associated with abdominal obesity. Abdominal obesity humorally increases TNF-alpha, L6 leptin, and decreases adiponectin. Adiponectin is, quote unquote, a good thing when it comes to carcinogenesis, so decreasing it is a bad thing. Then you have a mechanical aspect. It increases the pressure inside the stomach, so it increases the amount of relaxation that the esophagus does, which increases the exposure of the esophagus to acid. The increased intra-stomach pressure expedites, promotes, and potentiates the formation of hiatus hernia, which further increases reflux. All of this results in increased transition between reflux and Barrett's esophagus, and those with Barrett's esophagus to esophageal adenocarcinoma. This, you can take my gut feeling plus the data. There are studies for almost every arrow in this diagram. This is not a conceptual, although partly it is conceptual, but it's conceptual plus data on top of it. Then we come to H. pylori. Some of you may not have heard of what I'm going to say, so pay attention. H. pylori is a bad player, okay? So it's been linked to increased risk of peptic ulcer, gastric cancer, gastric maltoma, gastritis, and even possibly nonspecific symptoms. Here I'm talking the opposite. The thinking is if you have a stomach that is infected with H. pylori for a long time, it loses the capacity to produce acid, and therefore, if the person has reflux, whatever the reflux is just less obnoxious or noxious than someone who does not have H. pylori. So what I'm talking about now is H. pylori inversely related to the risk of Barrett's and esophageal adenocarcinoma. I'm sure you still remember the first slide that I've shown, where it shows the UK, the Netherlands, the US, da, 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 da. This is a completely different slide from a completely different source that shows the prevalence of H. pylori in countries, and take my word for it. It's almost the exact mirror image, inverse of what I've shown for esophageal adenocarcinoma. So this is ecological. I'm sure if I show enough pictures of those, you'll find, sightings of Elvis and storks and all of those things. But here there's more than ecology, and I'll show you a few studies. This is basically the summary of many, many, many clinical and epidemiological studies that show no consistent association between whether H. pylori is present or absent with reflux symptoms. Most of these were cross-sectional studies, so they're but some after removal of the H. pylori. Here where we start having some consistent relationship from endoscopic studies where the absence of H. pylori is associated with the presence of Barrett's esophagus. When it comes to esophageal adenocarcinoma, it's all observational studies, but the link, the inverse link, is quite striking. There's a consistent inverse association between the presence of Helicobacter pylori or its aftermath, which is gastritis, or its aftermath that went wild, which is atrophic gastritis or pangastritis, and the presence of esophageal adenocarcinoma. So a 25 to 50% lower likelihood of HP in the presence of BE or esophageal adenocarcinoma. I will admit, this is probably the least practical observation of my talk. So I'm not saying go ahead and infect people with H. pylori to prevent esophageal adenocarcinoma, but as I will explain in a second, it's one of the major explanations for those racial and country diversity in the observations that I listed. How does it work? I just put it again. It is thought that it just unearths whatever reflux does. So if you're infected with H. pylori, you see only the tip of the iceberg as far as bad complications of reflux. If there is no H. pylori, then you have a lot more acid, a lot more healthy stomach. So it just increases that tip that is visible. So to put it together, 70% of esophageal adenocarcinoma can be attributed to the following risk factors. Reflux, I didn't talk about smoking. It's a small, weak, but consistent risk factor, unlike squamous cell cancer, where it is the risk factor, and obesity, particular abdominal obesity. Then you have protective factors, H. pylori infection, and there's observational studies about both aspirin, NSAID, and statins. Commonly asked questions from patients and doctors, but no link between Barrett's esophagus, esophageal adenocarcinoma, and the intake of alcohol, coffee, tea, carbonated beverages, all that stuff. Chili powder. So my next phase now is to say, I talked about the risk factors, the protective factors, and the ones that don't play any role. Where do they act? Since this whole spectrum is normal, then Barrett's, then adenocarcinoma, where does the risk factor act? Is it converting the normal to Barrett's? Is it the Barrett's to adenocarcinoma? Or both of them? So this is conceptually what my next table will show. You have normal, you could go to Barrett's, you could go to adenocarcinoma, or theoretically you could jump. And knowing how to prevent something, you really need to know where does it work. So do we have information on that? This is a dense table, but I thought it's much better than showing you individual studies. So male sex, okay, it's mostly on the formation of Barrett's esophagus as opposed to the progression. So why is that important? Because part of the screening for Barrett's esophagus, many of the guidelines incorporate the word men in it. But once you have Barrett's esophagus, surveillance for cancer, you can't stratify by men or women. Once you get to the Barrett's level, yes, the risk is slightly lower in women, but the clinical implications are less. White race, it's almost exclusively the studies talk about the formation of Barrett's, not the progression from Barrett's to esophageal adenocarcinoma. Clinical implication, again, when you screen, when you have a white or Caucasian or a non-Hispanic person who's a man, that's sort of your biggest target. That's gonna probably catch 50 to 60% of all Barrett's. Reflux, it's mostly Barrett's, some evidence for the progression from Barrett's to esophageal adenocarcinoma. That is a big deal clinically, because that's where we get asked, do I put them on a PPI? Do I put them on a PPI for 1 year, a PPI for life? Do I put them if they have Barrett's even without symptoms? And I'll show you some clues to what your answer should be. Obesity, it's mostly Barrett's. Smoking, both ends. Taller heights, there's good news here. Taller people, you're less likely to get Barrett's esophagus. I'm not sure what the link is, but has been shown in some consistent things. And no, shortening operations don't reverse that. H. pylori acts mostly at the level of Barrett's, and then rologenetics. Okay. So I'm going to go back just to remind you of the discrepancy. And now I'm going to try to explain where those risk factors differ. So the sex disparity, men greater than women, tends to be partly, but not completely explained by the following. Gerd symptoms, it happens the same, men and women. Smoking, it doesn't. Intra-abdominal fat seems to be the leading factor in explaining the difference between men and women. And the general observation that men carry more fat, pound for pound, in their belly, as opposed to their trunk or buttocks, compared to women. And abdominal fat, especially visceral fat, is the main risk factor for Barrett's esophagus and esophageal adenocarcinoma. So that is the leading contention here. You would think it should be hormones, but the studies on hormone and receptors and the replacement haven't really panned out. How about race differences? White greater than especially black. Gerd symptoms, they're equal between the two groups. Smoking, they're equal, and you could argue slightly more actually in African Americans. Abdominal obesity still is the leading contender to explain those racial differences. It's been shown from large epidemiological studies that whites carry more fat, pound for pound, people of equivalent BMI or weight. Whites carry more fat in their belly, especially visceral fat, as compared to African American, where it's a different distribution. The other explanation is, and it's not mentioned here, is Helicobacter pylori. So African Americans tend to be disproportionately highly infected with Helicobacter pylori, therefore they have less healthy stomach, therefore even if they have reflux, whatever their refluxate is not that bad. So waist-hip ratio, African Americans are less likely to have high waist-hip ratio. They're more likely to have H. pylori, and because they're more likely to have H. pylori, they're more likely to have chronic gastritis. Okay, so that is the first use of epidemiology, is we explain something that seems to be inexplicable, and at least we paved the way for, guys, if you want to invoke that Coca-Cola is a risk for esophageal adenocarcinoma, you have to sort of explain what comes with that. You have to explain why should men be at a higher risk if Coca-Cola is drank more disproportionately by women, for example. So that's one benefit of epidemiology. The other one is it helps you to do risk stratification. So when you're in an office, and I see Tom Vaughn there, is developing calculators to, in a primary care setting, you get numerical gestalt of the risk of Barrett's and esophageal adenocarcinoma, and there are such calculators published. So this one builds on BMI, age, and reflux, and smoking. And the more you get here, the more likely you're going to have reflux, more adenocarcinoma. This is more than 600-fold in this person who's a current smoker, who's 70-year-old, whose BMI is greater than 30, and he has reflux and is using PPIs. So that's where our gestalt comes from, is if you look at someone like that, you would say endoscopy, or at least consider excluding Barrett's esophagus. Look at the extreme end, young person, no reflux, no PPI, thin, doesn't smoke. Their risk is nothing. So in that person, the odds are likely that even if you scope them, you're not going to find anything. Okay. Why is that also important? So 10 years ago, I would give you this. This whole talk would have been slightly irrelevant, because then you find Barrett's, and then there's a whole dilemma of what to do. Do you look at them all the time, some of the time? If you look at them, it's too late. If you look at the good ones, they never progress. The bad ones progress, and you can't do much about it. Well, a lot has happened at the back end or front end after you find Barrett's. And this is not the purpose of the talk, but to tell you that finding Barrett's, finding Nemo, is really important in this context, because you can change their course, there's good treatment for them, and things are developing in that area that it's not a useless diagnosis for you to find. So there are all those things that now available, most of them are available in routine practice, where you can see things in a way that we didn't used to see. So we can identify Barrett's better, and we can identify dysplasia in Barrett's better. The other thing is, there are ways that are evolving based on this epidemiology to detect Barrett's in a less invasive way. They're not there in the scope place next door to you, but they might be coming. One is transnasal endoscopy, and I apologize for the animation. I hate animation normally. But basically, you can put a thin scope through the nose and do it as an outpatient with minimum discomfort, and therefore you don't have to have the expense and the discomfort and the delay that happens with a regular endoscopy. There are studies, particularly in England, of a cytosponge. You basically swallow a sponge that is compressed on a thread, and then once it gets in there, it expands, and then you yank it out, and then you get cytology. And so things like that are happening, but you can't do them on everyone. And that's why the epidemiology is important, because it narrows it down to you, to a group where you can start tinkering around with these things. So this is actually a real person. He's a senior physician gastroenterologist at the Mayo Clinic who gave me this slide, and he's trying the sponge on himself, and he's smiling. Now, he's such a nice guy. He always smiles anyway, so this doesn't indicate that he's comfortable. But the other major development is, once you have dysplasia of any sort now, low grade, high grade, whatever it is, there's ablation. There's quote unquote cure. In the old days, that wasn't the case. When you find a dysplasia, you just watch it more carefully until you find the cancer. Now, you find dysplasia, you can actually get rid of it. So there's this something called radiofrequency ablation. It is tested really in high quality randomized trials versus sham. So this is what a Barrett's looks like. You put that balloon, the RFA, and you basically microwave it. So you burn the heck out of this, and it recovers, and a few weeks later, it looks like this. And it's actually, initially, it was very hard for me to believe that this is how the esophagus that used to have Barrett's, now with no Barrett's in it. And the durability is reasonable. 70 to 80% of those who are ablated well maintain an ablated Barrett's esophagus. Okay. So I'll just show you again, this is not the idea to explain the therapies and how they work, but the idea here is it's important to find Barrett's, because even if you find an early cancer, and this is an early cancer, the next one is endoscopic ultrasound showing thickening of the mucosa and a small nodule. And this is a case from our place, so this is real stuff. Put a ring around it, dissect it, looks like that. Then you subject it to the radiofrequency ablation. Then a few months later, it looks like this. Basically a normal esophagus, except for a residual spot here of Barrett's. No cancer remaining, no surgery, no esophagectomy, no's. So the impetus on risk stratification and understanding the epidemiology and risk factors of Barrett's esophagus and esophageal adenocarcinoma are becoming even more relevant. All right. Now, the third use of epidemiology. So we said explaining unexplainable things. Number 2, risk stratifying people. Number 3 is chemoprevention. So we're going to take all those, or prevention in general. I'm going to take all those risk factors that I talked about and say, what if we get rid of them? Do you actually reduce the risk of Barrett's and cancer or not? And the big one is PPIs, proton pump inhibitors. I will touch briefly on non-steroidals, and I will not touch on statins, only to say that probably not. So PPI and chemoprevention, this is a big deal, because most of the calls that we get right now, can I discontinue my PPI because I heard it increases the risk of dementia or something like that. And I would tell them, I've been on PPI for 10 years, and what was your name again? So, no, I don't do that. So here, PPIs are really useful, and I'm biased because of those 7 observational studies, 4 came from our group. So almost 3,000 patients with BE, exposed or non-exposed to PPIs, and it's consistently been shown in observational studies to be associated with a reduced risk of progression to adenocarcinoma of the esophagus. And the odds ratios are quite impressive in the negative thing. And there's some positive duration response. So the longer you're on it, the less likely you're going to develop cancer. There's some residual confounding, given it's an observational study, particularly not controlling for other medications that may affect the risk. But I personally take this data and advise more or less liberally patients who have Barrett's esophagus to use PPI, rain or shine. I am not talking about PPI to prevent Barrett's here. That is not clear at all. But once you have a Barrett's esophagus, it's safe to say use a PPI. It's not likely to hurt you. If anything, it may reduce the risk of future esophageal adenocarcinoma. What about the ultimate PPI? Surgery, lap nissen, fundoplication. So there are 10 cohort studies and 2 randomized control studies, and they detect a small but non-significant decrease in the risk. It is restricted to more modern operations, and if you restrict it to more modern operations and limit it to those with the underlying risk factors, in other words, Barrett's esophagus, you achieve statistical significance. It still says the same thing. If you intervene before the Barrett's esophagus, there's not a great source of data to tell you that you're altering the course. But once you have that intermediate, predisposing, precancerous lesion of Barrett's, decreasing reflux by almost any modality seems to be beneficial. So the bottom line, medium level evidence, grade 2A, grade recommendation B. John is the expert on this. He leads the AGA in developing those scores. But to me, it sounds like and Yeah, you know. So the evidence is okay. NSAIDs, observational, shows lots of studies show something that looks like this. People who are current users are much less to develop cancer compared to never users. Well, if you take this and put it in a randomized trial, we don't have the ultimate trial, we have one, and that one, unfortunately, is a negative trial. No difference between at the time they used the Coxib and placebo with regards to changes either in dysplasia or the degree of dysplasia or the surface area of Barrett's or a whole slew of biomarkers expression. So what do? So it may decrease the risk based on observational studies. We certainly don't have great randomized controlled trials, so I can't say one or the other. Introducing it for the sole reason of protection of esophageal adenocarcinoma is probably not justified. But those of you who follow the literature on aspirin and NSAID, the group that leads the field there are arguing for those combined benefits. It's no longer thinking of your esophagus and your colon and your heart, and you'll have a calculator that tells you the aggregate risk of all the bad things that people may have, and age drives almost all of them. So it seems like when you get to 50 to 60, taking a low dose aspirin is a good thing because you're at a high risk of something, and the more you get older, you become a high risk of another thing. So I find excuses, practically, to put people on a low-dose aspirin if they have Barrett's esophagus, especially long segment. What about hazardous waste? And talked about the transformation. Did it help? And what about lifestyle changes? So that's like bread and butter. Put blocks, don't eat before 3 hours before bedtime, small frequent meals, take some antacids, walk around. Does it work? Lifestyle change first to me, and this is going back to the hurricane. I decided after the age of 50 and losing weight is to introduce lifestyle changes. So I bought a Maserati. Truly, this is how my car looked. That's the only casualty of the damn hurricane. Our garage flooded. My wife's car stood still beautiful because it's an SUV, and mine just was totaled. So I was depressed for a couple of weeks. After, of course, you say, oh, we're so lucky, we didn't get hurt. But a week later, when I'm driving my dad's Honda Accord with a disabled decal on it, suddenly hit me. This is not good. So I went back to the dealership, and because it's an expensive car, they totaled it completely. And I told them, if you put me on the same lease, I'm ready to continue. And so as of 3 days ago, this is my new car, actually. So I'm almost going back to normal now. So not to get distracted, obesity treatment, no clear evidence, unfortunately, of obesity surgery, although the statistical power of almost all interventions for obesity is low. Because apart from surgery, there isn't enough people who lost weight and maintained that weight loss for you to examine the effect on something like a Barrett's esophagus. It makes sense that bariatric surgery, if successful, would reduce the risk, but the evidence is not there. I can tell you from a gastroenterologist perspective, I'm referring more people to bariatrics for the treatment of reflux than referring them to alapnicin for the treatment of reflux. And most surgeons prefer to do it like that. So why lap someone with a BMI of 40? Why not start with bariatrics, which may help multiple other things, including the reflux? Okay. So I'm getting to the end of the talk. The second phase here of the talk was in the prevention, and perhaps it's worth reading this carefully. So GERD treatment, using medications or surgery, tobacco cessation should be clinically recommended. It makes sense, but where? In patients with Barrett's esophagus. That's where most of the evidence is supportive of a benefit. While aspirin and NSAID appear to reduce the risk of esophageal adenocarcinoma, using them for that sole purpose is still equivocal. I told you about calculators that give you multiple risks. There are limited data for a protective effect for statins or hormone replacement therapy in women, but it's not really something that anyone can recommend at this point. Little evidence for potentially preventive role of weight loss, but I mean, you'll be nuts to tell patients that this won't work because it's going to work for something else, so might as well do it. And what I noticed actually anecdotally, and some of you might notice, is waist. So people notice which waist size really makes the reflux worse. And they know if I go back and become a waist 33, my reflux symptoms are done. And that I find very practical and objective, is like to reach to waist size. And if you're asking me, what does the epidemiology show? 34. Okay, 34.5 or so, that's when the risk of Barrett's esophagus and esophageal adenocarcinoma start going up. So maintain that or wear your pants low so you don't get that. Screening and surveillance for Barrett's. This was not about screening and surveillance for Barrett's, but I hope you have now enough information when you're sitting in the clinic and say, okay, this person needs screening. Once you do need screening part, it's in the gastroenterologist corner. They can decide on surveillance, but really, more than ever, you are doing something good by identifying people who are disproportionately affected with Barrett's. The introduction of preventive action should be tailored toward high-risk individuals. That's really the essence of the whole talk. So with that, I thank you again. You have 10 minutes for questions, and I look forward to seeing you this evening.
Thanks so much for coming out.
Thank you.
It is a Maserati.
It is. It's a Ghibli, by the way.
But it's interesting to know, so the obesity is such a hot topic. We can blame obesity on many things. Let's talk about obesity. If you look at the, some of my collaborators actually work in the Netherlands, and they were rather shocked about 7 years ago to see this exponential rise in esophageal adenocarcinoma. But if you go there, they're sexually tall, lean people as a whole. And yet their rate of esophageal adenocarcinoma far outpaces the rate of PAC in the US or in other countries. So this is why it's like, well, how could obesity, and they say, well, how could it be obesity? We're very, so I'm just curious, I mean, these are ecological kinds of observations, difficult to assess. There probably are obese people in the Netherlands, and maybe that's what it is, but what is going on there if you look at the population?
So I don't know about the Netherlands specifically, but what you point out, which I tried to say, is conventional measures of obesity at a population level, I think just about useless to explain what is the intermediate risk factor, what is quote unquote going on. So you may still have, I mean, Indian subcontinent, for example, very lean, thin, tiny people who have severe insulin resistance, reflux, and non-alcoholic fatty liver disease. And they are the antithesis of anything you could see to say this is, and what is the deal? Well, the deal, they have this inexplicable increase in visceral obesity. So almost all their fat is VAT. And anyone who practiced in the Indian subcontinent, including many of our residents, said, oh, we know that. I mean, those people, and we don't know why, but they have that. So it may be like this in the Netherlands, it may be the smoking, it may be another lifestyle risk factors, I don't know. But I think it's important to look slightly beyond BMI in order to understand what the risk factors are. So waist-hip ratio is getting there, but I think as we become more sophisticated in measuring the distribution and the type of fat, that may be more important than just a BMI. Yes.
Just a question about the cognitive studies. It's like all the other, many of the other studies which were done for randomized trials prospectively based on the observational studies of traditional NSAIDs, ibuprofen and naproxen. There is no incentive for the drug companies to study those. So they studied the COX-2 selective NSAIDs. We really don't know how that relates to a standard NSAID. It's just, we would probably never know. But it's just important that they are a subset and that the studies, most of the preventive studies randomized use the COX-2s.
Let me repeat this because it's really an important point. I've shown the one study that was negative, and it was done by a COXIB. And the comment was that the pharmaceuticals that manufacture COXIBs are the only ones who are willing to do anything related to randomized trials, while the conventional NSAIDs, which may have at least an equivalent, if not better benefit, may not be tested like that. And the short answer is yes. And that's why most people are using the observational evidence. And that's why people have attempted to lobby the NIH for a large prevention trial. Many things derailed that. One of them is it's still a rare cancer. It requires a lot of follow-up. But what really derailed it now, which gets to some of my talks, is the ablation. No one is going to sit there and watch anymore. So once you have early markers of progression, the clinical practice has changed to complete ablation. And therefore, seeing if the NSAID worked or not becomes even a much higher bar. It has to prevent the first sign of low-grade dysplasia, because everything after that is over.
So if you go back to story,
Yes.
it's clearly an observation.
Yes.
So,
okay.
So why is there any explanation, or is it the same as a study about 100 years ago that showed that the decrease in birth rate in plants is parallel to the decrease of the amount of stores?
Yeah.
Is that something like that? Just
no.
Incidental?
I started by the ecology joke, and I actually mentioned the storks, so we were talking about the same thing. The real studies, which is individual level studies, confirm the inverse association. So that in my mind, is done. The question is why? And there are multiple studies, I didn't mention them for the sake of time, that looked at the mechanistic issues. So acid output is really decreased in pangastritis. The distribution of gastritis is really affecting the risk of Barrett. So those who have gastritis that extends both in the antrum and the corpus have less Barrett's. Those who have atrophy, where the stomach not only is inflamed, but loses its acid capacity based on extensive histopathology assessment, are also associated with even more reduction. So while the initial observation falls into this ecological fallacy, maybe it's just stuff, the further individual level studies seem to confirm not just the observation, but seem to give us clues about the mechanism of the observations. So I think, at least I am convinced, that it plays a small part of that equation. There are parts of the world that don't see esophageal adenocarcinoma, which is remarkable. I mean, Japan, which is not an inferior country, they certainly know how to scope better than us, and they scope more than us. Until recently, they've never seen esophageal adenocarcinoma. It's all squamous, squamous, squamous. And then what changed in Japan? Well, I mean, they used to have 90 to 100% prevalence of H. pylori because they developed their society so fast, it plummeted down, and they're moving into a Western type of diet, and they're gaining weight. So that country seems to fit the paradigm more than Netherlands, admittedly, where the Netherlands is a known hub of that disease. So that's why those anecdotes makes it to me even more compelling that it is something, or one of those three things that we're talking about. Something I did not talk about, but it's very difficult to examine, is whatever people put in their mouth must play a role in a disease that sort of is the gateway to the stomach. But dietary studies are very difficult to conduct. If you've seen the questionnaires, it tells you how many peaches you ate last year. I mean, it's just very difficult to quantify what is that harmful thing and to relate it to conditions. Some people did not eat peaches last year. This is Seattle, guys, come on. We're a barbecue country, but yeah. All right, let's go.
Sorry, again, so you mentioned family history, and the question really is polygenic risk and the ability to discriminate, and that some people in your group have looked at this. And so where are we with the ability to look at genetics and understand risk?
Yes, a great question. So the question, what about the initial observation, which is almost in every disease, bad things happen in the same family. So when they scope relatives of patients with Barrett's esophagus and esophageal adenocarcinoma, they tend to have slightly more Barrett's than those whose index case did not have an esophageal adenocarcinoma or Barrett's, which led to, okay, well, there's a familial clustering. Familial clustering could result because of environmental shared things and or genetics. And there have been lots of genetic studies that people have done. Tom Vaughan here was part of this Beacon consortium, and they found the usual, several hits that make sense that are statistically significant. So what's the next step is to take those and put them in the calculator that I've shown you to show whether they improve the risk prediction or not. I think I'm allowed to reveal it because you're the editor and I'm the reviewer, but they're publishing this data in Gastro pretty soon, and it just doesn't add that much. You're almost just doing as good by asking someone, do you have reflux? Do you take PPI? Are you obese or do you smoke? All this research, which is extremely elegant, led to identification of really important hits. But if you put them together in a risk stratification, they barely give you any additional value. That aside, if someone tells you, my father, my brother, my sister, my mom has Barrett's esophagus, esophageal adenocarcinoma, you close your eyes and you scope them. I mean, this is really, maybe I should mention this. I mean, those are rare conditions. So if someone tells you my dad has a rare condition, their risk is so high that don't ask any more questions. It's done. Welcome to the GI endoscopy suite. We offer in Houston the We offer them the shish kebab special, which is, if you get two, we discount you a little bit. All right, thank you very much again.